Good evening, everyone. Thank you for joining us for the IDF Forum Managing Chronic Symptoms with PI, a practical information guide. I'm Kathy Antela, Vice President of Education at the Immune Deficiency Foundation, and I will be your host this evening. So before we begin, as always, a quick disclaimer that the information tonight is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of your physician or other qualified healthcare provider with questions concerning a medical condition. So on behalf of all of us at IDF, welcome, whether this is your first time or you have been with us multiple times. We are so glad you're here with us this evening. IDF's mission is improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. This means we're committed to serving you and providing you with the tools and resources needed to be your own best advocate and a champion in the PI community. It is by offering these tools and resources that IDF can fulfill its vision of seeking to empower, ensure that everyone in the US is affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities for connection and support within the PI community. IDF forums are made possible by our wonderful sponsors. It is due to their partnerships and contributions that IDF is able to provide programs such as this one this evening and services to everyone in the PI community. So thank you to our 2021 sponsors, Core Services Leaders, CSL Behring, Grifols, and Takeda, Core Services Supporter, Horizon Therapeutics and Octapharma, Core Services Sustainer, Accredo, Core Services Contributor, ADMA Biologics, Bioproducts Laboratory, and X4 Pharmaceuticals, National Patron, Kedrion Biopharma, and Community Partner, Celio Health. Upcoming events, we've always got things going on, and one of the year-round nationwide events is our Get Connected groups. These are small networking groups, all virtual, and they occur throughout the nation, throughout the year. Great opportunity to meet others in the PI community and share, learn, and have fun. Then we have some additional forums coming up. Next week, on the 20th, we have general care for individuals with PI. Many of you have asked about that. So looking forward to sharing that information with you. And then in June, we have 2 forums, and these are not on the calendar yet, but they will be within the next couple days. One is integrative medicine and PI. And the other one is the role of family in chronic illness. So we look forward to having you join us for those events. And then it is a big conference year. And this year, unfortunately, we are not getting together in person, but we're going to get together virtually. The IDF Primary Immunodeficiency Conference will be held virtually June 23rd to 26th, and it is a free event. People from around the world in the PI community can register. There will be programming for ages 5 through 105 or 115. So we look forward to having you join us for that. We have about 50 sessions, which include networking by diagnosis, networking by age, networking whether you are an individual, a young adult with PI, or you're a caregiver, spouse, partner of someone with PI. You name it, it's there. And if it's not there, it's going to be offered at an upcoming forum. So just keep letting us know what you want. And you can register now. Go to the calendar events and sign up. And now the moment we've all been waiting for. So now I would like to welcome and introduce our presenter, Dr. Patricia Lugar. Dr. Lugar is board certified in allergy and immunology and internal medicine, and she sees patients at Duke Asthma, Allergy, and Airway Center in Durham, North Carolina. So please join me in welcoming Dr. Patricia Lugar.
Okay, good evening, everyone. Well, thank you to everyone who is here tonight. And I realize that one of the good things about the pandemic is that people can get together virtually. We probably would have done this in a small little room, but now we can meet people, anyone who has a computer and Wi-Fi and would like to connect. So I really appreciate the IDF for reaching out to me to do this talk. And hopefully it's informative. Hopefully it's of value to folks who are joining us tonight. If anyone wants to get a little glass of wine or get a little hors d'oeuvres, some brownies, if it is in your time zone for dessert, go ahead. I hope this is fun, approachable, and as I said, valuable. So thank you for joining me, and we'll get started with the talk. So the title is obviously Managing Chronic Symptoms. And the first thing that I'd like to say is, what do we mean by chronic symptoms? I think when we are certainly connecting about immune deficiency and many symptoms associated with immune deficiency are, right there in our face. We think about infections, we think about chronic infections, but for chronic symptoms and for people living with primary immune deficiency, no matter what the diagnosis of immune deficiency is, we understand that there are things beyond the very obvious that patients experience that are certainly could be related to the immune deficiency. And I hope that this talk gives you a run through about, let's start thinking about where these symptoms are coming from and what we can do. So we'll go through this as truly a practical informational guide. So when I see patients in clinic with immune deficiency, and we talk about chronic symptoms, this is again about beyond what we're talking about for immune function, but they may have chronic symptoms related to the respiratory tract. That's probably number one, and quickly followed by gastrointestinal tract. There may be some issues with blood counts or low platelets or chronic anemia that we have to deal with that, again, is not necessarily because you have an immune deficiency or not wrapped up into what people think about for an immune deficiency. Musculoskeletal complaints, and then general well-being, fatigue, depressed mood. Certainly these are chronic symptoms that our patients have to deal with, and we need a little guide as to what's the physical component and what is beyond that. So to get started, I like to also tell patients that when we're first meeting and when we're sort of going through treatment plans, and if there are a lot of chronic symptoms to go through, I frequently like to develop a team of trusted specialists, depending on where my patients need help the most. We tend to do a lot of outside our specialty diagnosis, workup, and evaluations. We do a little, we can order GI testing, we do some imaging, but frequently I like to have a team of specialists that know the patients well, so that when it gets beyond what I know how to do, or when I need potentially something maybe more invasive, or if I need a procedure done, we have those folks in our care team as our care team. And it might be something that's just a one-time consult. It might be someone that helps us with routine follow-up. So let's get started. So by chronic or common symptoms of the respiratory tree can be cough, shortness of breath, wheezing, exercise intolerance, feeling tired or getting early quick fatigue with limited activity. these are things that we might investigate in the respiratory tree. We're always going to think about infection, and common causes for these respiratory symptoms can certainly be infections. We can have infections that are chronic, like chronic sinusitis by definition can be a bug that was just never cleared. And so we go after cultures when we can. And frequently that can end the cycle of chronic sinusitis in our patients. Sometimes it's a typical pneumonia or a chronic bug that's living in the respiratory tree that just didn't get cleared. And so sometimes cultures can be really helpful to tease that out. Sometimes it's not related to an infection, but it's related to changes that occur inside either the airway, the highways of the lungs, or outside of the airways in the lung tissue itself. And sometimes it's just inflammation. Asthma is a great example of chronic inflammation that lives in the respiratory tree. Many people with immune deficiency have asthma. Some have other fixed airway obstruction or changes in the airway that have been misrepresented as asthma. So it's really a goal of for myself and for a lot of immunologists to make sure that we're labeling what the cause of these symptoms are as accurately as possible, because it really impacts how we approach managing those symptoms. Interstitial lung disease, which happens in patients with autoimmune disease, certainly happens in patients with primary immune deficiency. And granulomatous disease as well can happen in a number of immune deficiency, antibody deficiency, and also other immune disorders such as CGD, for example. And there's a condition that occurs in patients with CVID, a common form of an antibody deficiency that combines asthma, interstitial lung disease, and granulomatous disease. And this is called by a large name, GLILD, or granulomatous lymphocytic interstitial lung disease. And so that is something that is really, we say pathognomonic, meaning that when it occurs in a patient with CVID, we know instantly it is GLILD. And that can have very drastic differences in management than simple asthma would have, for example. So how do we manage chronic respiratory symptoms? Well, certainly once we have an idea what the cause is, we have the symptoms, we get to the cause, we can aim our treatments specifically at what we're trying to regulate. If it's inflammation, we're probably going to be using medications to suppress that inflammation. We tend not to use prednisone. We don't like to use prednisone. We can use inhaled steroid medications. Sometimes we do have to use prednisone, although we're pretty stingy with the prednisone if we can be. But there are other immune suppressant or modulating medications that can be used. And again, it really depends on what our evaluation has told us. But this would be an example of some medications we can use to manage these chronic respiratory symptoms and their causes. So what to expect? Well, if the chronic respiratory symptoms are something that you struggle with, I certainly would expect to have some functional testing, meaning what is your capacity, and a pulmonary function test or spirometry is a great way to look at the capacity of respiration, air in and air out. And roughly we expect that to be fairly equal. And when it's not, it makes us think about some inflammation that occurs in the airway itself. It may be that you can't get a deep breath in, you can't get that air in as we would expect you to for your size, your height, gender, your age. And that might suggest that there is some scarring or limited capacity to expand. If through these assessments, it looks like there might be a problem either with expansion or problems with mucus or changes in the airway itself that might be impairing how well you can breathe, imaging would be the next course. We also use sputum cultures quite a bit. We'd rather do a sputum culture when there's acute cough or respiratory changes because it is very valuable. Countless times we've been able to identify if it's just a odd bacteria that got in there that just didn't clear or resistant to other antibiotics tried in the past. So those highlighted asterisk items are things that are done frequently and can usually get at understanding and defining what to do about those chronic respiratory symptoms. Rarely do we have to do something more invasive like bronchoscopy, which is very similar to endoscopy that's done for the GI tract. But we look at the airway, look inside the airway at the airway tubules and the airways. And it's a great way to sample some fluid for some patients who really can't cough anything up, or if we're trying to look at what are the cells that are causing this inflammation. Rarely that is not enough, and a lung biopsy may be recommended. But the top three are something that for my practice, we frequently do, and we can usually get away with that, getting to the cause and managing the chronic symptoms before we need to look outside there or get a subspecialist involved. But what can you do when you notice a change in these respiratory symptoms? Well, we really don't like folks to wait things out on their own. If it's a new cough, a cough that won't go away, maybe you've been working with your primary care doctor, it's bronchitis, I get bronchitis, it's bronchitis again. But your primary care doctor thinks, well, maybe we should do steroids this time, maybe it's asthma. So we like to, if things are not resolving on their own with simple management, there's nothing wrong with going to your primary care doctor. Certainly, if you need something more urgent care or the ER, depending on the symptoms are difficulty breathing, or you're struggling with very simple activity, then please get evaluated. But if it's something that is truly chronic nature and has been going on for a while, then I really feel the immunologist needs to be involved and may or may not be part of your preferred team to get pulmonary involved as well. So I have here frequent areas of confusion. So a lot of folks ask us, okay, I go to my primary care doctor, I go to urgent care, and they give me antibiotics, they give me steroids, either it works or it doesn't work, or maybe they come back and they tell me, hey, in the 6 months since I've last seen you, I've been on 4 antibiotics for this cough. And so I think there's a lot of confusion about how to manage that. People are certainly thinking immune deficiency, you're probably having infections. Believe it or not, we frequently find some of that list that we talked about, there could be other contributing factors that are why you're having those respiratory symptoms, particularly if it's been going on for a long time. My point is that just because you have an immune deficiency doesn't necessarily mean that all of your symptoms should be blamed on infection. It frequently can be, but just as many times we'll find that it may not be at all. And we need to do some deep dive, a little more digging to find out what the underlying cause can be. Again, we really don't like to do steroids unless we absolutely have to. There are other forms of immune suppression that we can use. It's not a no-no. Sometimes we need to use it when there's a lot of inflammation in the lungs. We've even have some patients who might benefit from lung transplantation just due to chronic infections or scarring of the lung. And they say, hey, you can't get lung transplant because you have an immune deficiency and you can't have any further immune suppression. Well, that may not be a full story. We've had some nice examples at Duke. Right, so GI symptoms, well, I said it's probably the second most common. It certainly is. Change in bowel habits, abdominal pain, new food intolerances, weight changes, bloating, reflux. I can't tell you how common reflux is, and reflux can be quite silent, and we may not even realize that during the night there is reflux activity that's flaring up, sinusitis, flaring, and even frankly causing your bronchitis. And so it's very important. We always ask about GI symptoms. Sometimes people are probably tired of us asking about their bowel habits and their GI symptoms, but it can really play an overlap into other organ systems and how you feel in general. We can have malnutrition from recurrent diarrhea, and that could be contributing to fatigue and some other changes in skin, nail, hair, without really understanding how frequent the diarrhea is or how long it's been going on, not really knowing if these malnutrition or these micronutrient deficiencies can be set up fairly commonly. So it's all part of checking these symptoms out. Common causes, our list will always include infections, and it can be because of infections that are something that we're picking up, of course. Food poisoning, there's a greater susceptibility to that, as well as to parasitic infections, though it's not so common here in the US, but certainly can. Patients can pick up Giardia, for example, which is a common parasitic infection. But there could be dysbiosis because of prophylactic antibiotic therapy or because of recurrent antibiotics. There can be overgrowth, or we call dysbiosis, where there is altered bowel habits, constipation or diarrhea, usually bloating, and just general discomfort in the GI tract. And that could be because of this altered microflora within the GI tract. It could be frank bacterial overgrowth syndrome, and that can be treated with a very specific type of antibiotic. We really worry about chronic viral infections. That happens from time to time. It can be very difficult to clear these types of infections. Giardia, C. diff infections, which can occur from antibiotic use, viral GI infections, such as occurring with norovirus, cytomegalovirus, or CMV, and also H. pylori. They're just difficult infections to clear. Other causes for GI symptoms, celiac disease, and many patients come to us because a low antibody level might have been found on a celiac screen. So we know they already are having chronic GI symptoms that made their provider or a gastroenterologist think about celiac disease. And that is certainly more common in antibody deficiency, especially with IgA deficiency. So it really does occur. Now that has to be distinguished from a condition called CVID enteropathy, which can look pretty indistinguishable and act exactly like celiac disease, but it is a little bit different in people with an antibody deficiency called CVID. The common causes, small bowel bacterial overgrowth, as I alluded to, other autoimmune conditions such as inflammatory bowel disease can occur more commonly in patients with an immune deficiency. We've seen lymphoma of the small bowel, and that could be causing symptoms, lymphocytic colitis, nodular lymphoid hyperplasia, pernicious anemia, and gastric or colon cancer. So lots of causes, and not to get anybody worried, but I think most immunologists are sort of running through this list in their head when patients have particularly a change in bowel habits, or if their bowel habits have been maybe tending to run toward diarrhea or loose stools frequently, then all of a sudden there's a change that this is not like how my pattern used to be. Then we need to think about the infectious causes and potentially the inflammatory causes. I wanted to spend a little bit of time talking about problems that occur sort of upper GI tract and then the lower GI tract. Years ago, when I first got into immunology, and this is decades ago, we used to think that if you had CVID, a common antibody deficiency, that you were more prone to developing certain types of cancers, including cancers of the stomach. Since then, and we've done some research on this topic, particularly cancers and CVID, we're not finding the rates of gastric cancer nearly as high as we had in reports from the 70s, 80s, and 90s. So the thought was that previously H. pylori, which is a Helicobacter pylori, a bacteria that is quite transmissible and can be found in household members. In other words, we can transmit it to household members. It certainly can be transferred through occupational exposure, such as to nurses. And so it is something that we can pick up from within our household. And some people may have absolutely no symptoms of it at all. Other patients may have symptoms that are similar to a chronic abdominal pain, like a stomach ulcer, having symptoms that might be a gnawing pain. There may be some blood in the stool, or it can just be bloating, gas, and discomfort every time they eat. Or it can be that they have stomach pain that's chronic, gets a little bit better with food, but doesn't completely go away. Those can be H. pylori infections. It's thought that because patients have access to antibiotics and are on antibiotics, for some reason, it's cutting down the rate of H. pylori infection. We're not seeing it as much as we had decades ago. And this is the thought that may contribute to why we're seeing less H. pylori infection in patients with immune deficiency, particularly CVID or IgA deficiency, and as a consequence, less gastric cancer. But it is something that is on the back of our minds. And there are some experts, GI doctors, who are familiar with CVID, who say, look, when we are first picking up CVID in a patient, we should probably just test them for H. pylori at the time of CVID diagnosis. And that can be done with endoscopy. It can be done with a breath test. It can be done with the stool antigen. The antibody testing that is done would not be effective in patients with an immune deficiency. I'm not sure I'm 100% on board with that. We usually take a more detailed history, but I am quick to get the testing done if there is some suspicion, because again, we really would want to pick that up. If there is abnormalities picked up through endoscopy, we usually like our endoscopy through routine screening, or we call it surveillance, to be done every 6 to 12 months. And that is because of that risk for gastric cancer in that population. A little bit about the lower tract of the stomach, or GI tract, be it below the stomach and small intestine. So from an infectious standpoint, we've had several patients who have had really bad diarrhea, and it may be associated with pretty profound malnutrition, weight loss, and then some secondary problems because we can't keep their nutrients normal. They may even have trouble keeping their IgG elevated, and this would really relate to patients with antibody deficiencies, where we see this predominantly. Norovirus and chronic norovirus infection can cause a really severe inflammation in the small intestine. Now, we normally see it in patients who might have had chronic immune suppression, maybe chronic prednisone for a respiratory condition, or because the physician is treating CVID enteropathy and they've been on oral steroids in the past. So I think the combination of that additional immune suppression plus the underlying immune suppression can open up a window for particularly viral, intestinal, chronic infections. And so we usually like to get a stool culture, but a culture that specifically is looking for viral infections. Protozoal infections would be these parasites such as Giardia. Doesn't have to mean that you were hiking or drinking water out of a contaminated well or a stream. You can get Giardia through other causes. And for that reason, we frequently will do a complete panel that looks for the atypical infections that can cause chronic diarrhea. But here's that word again, culture, culture, culture. it can be really important. And the simple cultures for people without immune deficiency may not pick up what we're looking for in patients that have immune deficiency. On to liver disease. I won't spend a lot of time on this, but we normally do get liver chemistries as part of our routine follow-up. And it's not uncommon, particularly for people with CVID, to have some abnormalities within their liver chemistries. Autoimmune disease affecting the liver can be a cause. There can be some inflammation that occurs in the liver that is thought to be fairly common in CVID as well. And so the important thing is that every time we try to think about autoimmune disease in our antibody deficiency patients, we must be cognizant that they may be unreliable, particularly if the antibody, your own personal antibodies that you make, are very low. And if you're being supplemented with plasma products such as IVIG or subcutaneous IG, you may not be representing your own body's autoimmune antibodies. And we can always talk about that at another time as to why that, how do you get autoimmune disease without detectable autoantibodies? But it's just important for patients to know when they tell me they did all the testing, but the testing didn't show anything, and they just looked at blood work. That may not be helpful in our unique situation with our patients with antibody deficiency. So what to expect? Blood work, potentially endoscopy. Sometimes we do food elimination diets. Sometimes we try probiotics. We do imaging as appropriate, liver cultures. Potentially outside of endoscopy, we need to do other more invasive tests, such as biopsies of the liver. Well, what can we do? You know, we don't see much benefit from IG immunoglobulin replacement in our patients with CVID, not necessarily on if it's non-infectious. Unfortunately, we don't tend to see an immune suppressive effect from the immunoglobulin as much as we would like to see on the GI tract. And so we frequently have to add other immune suppressive or immune modulating agents. Modulation means dampen the immune system without a full immune suppression, but dampening down that activation to manage inflammation. That can be done with a variety of medications. And truthfully, as we know more and more about the causes, particularly of CVID and neuropathy, we know that oral corticosteroids such as prednisone can really be, I don't want to say a thing of the past, but really is not the first thing we're going to grab off the shelf. It might be used acutely when we want to see, will you respond to steroids? But generally, there are medicines to spare you from steroid exposure that are much safer for your immune system and hopefully not set you up for a chronic viral cause of GI problems or just other chronic infections that can really throw you off and get you into trouble with trying to manage that chronic infection. Well, what can you do? As I said before, be aware of a change of symptoms. Sometimes we ask for food diaries. Be careful about travel and exposure history, particularly as we talked about with water parks and travel. You'd be surprised how people can pick up Giardia or just some nasty bugs and worms. I will say that when you're taking care of young children, if you are taking care of young children and it's norovirus season, and someone comes in and says, I'm having a lot of trouble with my gut, Dr. Lugar, and I know they have children in school, I am going to, whether or not the children had a high symptom load of norovirus, that is on our minds. And that's true for anyone taking care of children who are in elementary, preschool, younger, even middle school. It's important that we know about your exposures. I will say as well that it's important to just keep up with follow-up appointments because things can happen 4 months, 6 months, and if we're coming back in every 6 months, we may not remember that you had that travel or that exposure, or that you went through that rough period. Now it's chronic. And, lots of people have told me I've had this for 3 months now, and we don't really know about it. So, if you're not able to come in because you're living far away and we don't always know the workup that's been done by a local gastroenterologist or whatnot, just reach out to us. Your gastroenterologist may need help from an immunologist to look at some of these specific causes. Musculoskeletal, I'm not going to spend a lot of time on musculoskeletal, except to say that joint aches, pains, swelling joints, muscle aches. We always think of, for immune deficiency patients, that the immune system is not firing on all of its gears, that there's some misdirection with the immune system. And it may find it much easier to use its energy against our natural cells that are dying, because it's much easier to form an immune response against our own cells. And that can set some folks up for an autoimmune disease. And so it's really important that we try to rule that out. And frequently we try to use a rheumatologist that is aware blood testing may not be accurate in all scenarios. We're also concerned about bone disease and loss of bone mineralization. We've done some studies that have shown that our patients, and this is for males and females, although we have a lot more females in that group than we do males, but the onset of osteopenia, which means low bone density than would be expected for your age, and frank osteopenia, which is a more advanced form of bone loss, seems to occur at an earlier age in our patients with an antibody deficiency, CVID. Frequently, we go back and look for the cause. We find that steroids such as prednisone may be a strong factor, but it may also be chronic diarrhea and poor absorption of vitamin D, calcium. It may be due to poor mobility because of other conditions that you're experiencing or other chronic symptoms. And there's not a lot of that protection of the bones because of exercise and weight-bearing exercise like walking. And that may be contributing as to why we're seeing this observation in our patients. And so that's another reason why we recommend limiting steroid exposure, being mindful about risks when we have to do steroids, when we shouldn't be doing steroids. And then we try to screen our patients early for osteopenia and osteoporosis if we can, particularly if there's some risk factors there, such as steroid exposure before they came to see us. And then make sure that we're mindful about nutrition and nutritional goals. Lastly, I wanted to cover cancer because many patients, particularly with antibody deficiencies such as CVID, may have been told that either cancer is very, very common in CVID, or they may have had lymph nodes that were they can feel either under their armpits or on an X-ray or a CT scan, and they may have had biopsies done of these lymph nodes to make sure that it's not cancer or lymphoma. I also heard many patients will come in and tell me that, that they feel it's very likely that they're going to get cancer. And we've specifically done a lot of studies on cancer and immune deficiency, although it is a risk. And when we follow up our patients in clinic, we are looking for signs and symptoms that may be something we need to screen for, that we may have an appropriate screening for cancer that we need to do. I can tell you that as far as patients with CVID, we know that the risk might be higher for lymphoma. We know that the risk for gastrointestinal cancer, which used to be much higher, is much lower now. And I would say the second cancer that we see a little bit higher in our group of patients, particularly with antibody deficiencies as adults, are probably colon cancer as the next cancer. And so And skin cancer, I want to really highlight skin cancer, because skin cancer is really not thought of as a strong risk factor, but there are reasons that skin cancer can be ignored. And so we frequently, depending on patient's exposure, sun exposure, and what they do and their hobbies and whatnot, but that sometimes we have some patients make sure that they have annual dermatology visits to get screened. And so I won't go over this again. We pretty much spoke about that, and you'll have these slides, because I wanted to spend time a little bit on fatigue. So fatigue is a tough symptom. There's no organ where fatigue lives. Fatigue is us, it's the whole body. And we talk about fatigue, even if you suffer from chronic fatigue, your fatigue may come in spurts. You may have times where the fatigue isn't as bad and you can manage it. And then other times where you feel, how am I ever going to get out from this weight of this fatigue? And so as a physician, listening to how to manage fatigue and what should we do and what workup and how many tubes of blood are we going to take from you to get this fatigue answered, it's tough for me too to know where should I focus on you to help me understand what the fatigue is. We always go back and do a run through our head. Did we cover respiratory, GI? Have we checked your blood counts recently? Is there a new autoimmune disease here that we didn't pick up? What else is contributing to the fatigue? And that's really important, because we just spent a lot of time talking about all the other things that can happen. We're thinking about immune deficiency and managing infections, because that's so important. But so many other things can be happening in the background. And so we need to know the scope of your health overall. And so we're going to be looking in those other areas. If we find that I cannot see a cause for the fatigue, then we think about other causes. You know, I say that the first goal is to optimize the treatment, know the underlying cause, make sure that our treatment is appropriate. A change in fatigue could signal a new issue, and that's why we need to do this. It can be something very simple like thyroid or anemia, but oftentimes when patients are experiencing this, and if we find there's no other physical cause, we can gain a huge amount by having a real talk about how do we prioritize your well-being. Frequently, I've found that patients are not resting appropriately. And I know that many patients will say, I rest all day. How can this be? But there's a difference in stimulating your body and rest, and stimulation and rest. And so there's a real recipe here for exercise, understanding what good sleep is, understanding what a good diet, particularly for your body and your immune deficiency, might be. And we can go through that initially to get started. If we can manage pain, if we can manage stress, that high cortisol state, all the things that deplete us and make us fatigued, can contribute and put a little more power back into your bank. And so it may be very important for folks to set goals, set limits, set breaks during the day, particularly if you're parenting or taking care of a parent, or if you're working. It may be that you and your employer may need to know your limits. You know, maybe you can only give 6 hours at your best, and the rest you need to go home, rest, and then you can work from home beyond that. Or maybe 6 hours is all that you've got. Set goals, be honest with yourself about what you can do, and just not living with that guilt that you've overstretched yourself and now you're going to suffer for it, and you're still not meeting all of your demands that are on you. That can be liberating. You need to give yourself that break. Know how what your willingness is to speak about this with your employers or coworkers. You share what was only necessary is an approach a lot of people take, which might be a good approach until you understand what the community response might be at your job. Apply for FMLA if appropriate. We do a lot of that so that patients can get that break when things are going on that we need to work up a new problem or we just need to take a break. And then use your community. We just spoke about what the Immune Deficiency Foundation is doing to try to bring patients together. But I think you need a good support system that understands that maybe you look normal or you don't look like you have a problem, but there's a lot of activity going on inside that body that can allow you or require you to set limits. And so surround yourself with folks as much as you can that are a good support system for you, friends with chronic disease and without chronic disease, and participate in all these aspects of developing that support that bring value back to your life. And those are things that, working with our patients, have offered a new way to manage their fatigue. You'd be surprised what stepping back can do to make your day more valuable to you. And that's all that I really can surmise in this big topic today. So thank you for listening. If everyone is still on board, thank you for listening. And I hope this was valuable to you.
Thank you. Amazing, wonderful information, Dr. Lugar. Can't thank you enough for that. On we go to the Q&A session. And at this time, I would like to invite my colleague, Colleen Brock, Program Manager of Education, to moderate the Q&A session. So Colleen, take it away.
Thanks, Kathy. Thank you, everybody, for the questions you submitted prior to this presentation and for the questions that you have submitted. You have some amazing input and thought processes as far as chronic illness goes with PI. So the first one, Dr. Lugar, that I'm going to start with is chronic pain associated with PI? And if so, how might that be?
So chronic pain in itself, I can't say that chronic pain in itself, I cannot say would be something we would expect to find in immune deficiency. Now, I don't know what immune deficiency the person that's asking the question is looking for some clarity on. Chronic pain without an identified cause is not something that I would say would be something we'd expect from the immune system. That's a tricky question because chronic pain in someone who has a autoimmune disease such as rheumatoid arthritis or undifferentiated autoimmune disease that affects joints, muscles, certainly, that can be associated with primary immune deficiency. But chronic pain that's undifferentiated and doesn't have a real home in a cause, I can't say that would be directly associated with the immune deficiency.
Okay. Well, in talking about tissues and muscles, there's a question about connection between PI and connective tissue disorders, such as Ehlers-Danlos syndrome.
Ooh, that's another very, very good one.
They're on top of it
yes,
tonight.
That is a really good one. I will say that I have looked. I believe that we might, and that actually refers to the question before, because in Ehlers-Danlos syndrome, chronic pain can be chronic pain affecting particularly the muscles or deep pain can be seen in that condition. So I would say stay tuned. Doctors need to know more about this, particularly the type 4 that doesn't have a genetic cause and there's just hypermobility. We see a lot of other symptoms associated with that hypermobility type that I do believe affects not only the vascular tree and collagen and how our tissues are structured and injuries, but I have many patients that come in for an immune evaluation, and I suspect there is a relationship. And as we understand more about genetics, because we do a lot of genetic screening, we see genes that have no place in the immune system, but they're genes associated with the development of the musculoskeletal system that are probably going to be a relationship. So I think we will see a relationship between certain autoimmune diseases and EDS. But we don't know right now. We don't have an answer, but I think it's a great question. And I'm suspicious that there's a relationship. And as we do a little bit more digging into the genetics and what and how it relates to the immune system, I think we're going to find lymphatics and other key points of immune connections are going to be affected by EDS.
Interesting. Thank you. I have a person here who gets diarrhea after their sub-Q infusion. Is that something that is common, or how should they deal with it?
So it's not common. It can happen. We don't have a good reason for the mechanism for that. I've had patients, I don't even know if we have some of my patients that are on this meeting, but we have had patients that have experienced that. I have switched their brand. We have looked to make sure it's nothing that they're doing on that particular day. For example, we tell people to hydrate, hydrate, hydrate. And some folks that shows up as diarrhea for them. So we have to be careful about hydration. Sometimes it's the pre-medications that they're taking. And sometimes we can't figure it out whatsoever. And usually for those patients, we switch the brand to see if it's better.
Good. Staying with GI questions, are there tests for malabsorption? And which doctor specialist would do those kinds of testing?
There are tests for malabsorption because we expect certain things to appear in the stool at a certain ratio. And we could see, we can pick up malabsorption through stool analysis. And that's probably the best way. There are some blood tests that can be done too, but mostly we look at fecal sample or stool samples to pick up malabsorption. And then oftentimes we will run some micronutrient levels to see if there's appropriate absorption going on for essential vitamins and minerals. Usually we work with gastroenterology. We will start with some of the blood work and we will refer for endoscopy to be done and with the stool cultures. And that's, or the stool analysis, sorry, it's not stool cultures, it's stool analysis. And that's usually done the stool analysis with gastroenterology.
Thank you. Can CMV cause chronic GI problems in a patient with CVID? And if so, what should they do?
Yes, it can. Generally, patients with CVID who run into chronic GI issues, upper, lower, that CMV is suspected, are usually patients who have had immune suppression beyond their immune deficiency. So we tend to see it not just in a patient with immune deficiency, CVID, or other immune deficiencies, but if they've had sort of a secondary hit or even a prolonged illness where the immune system is secondarily suppressed. That is picked up through special stool cultures looking for the viral infection, and frequently best done on endoscopy.
I've had two people that have asked me about colonoscopies. One who says, should they get them more often than the general population? Another who said they have avoided and have not gotten a colonoscopy for fear of getting an infection because of their CVID. So what should patients do?
Excellent questions again. I am in the camp of endoscopy. I really am. I've seen firsthand the benefit to knowing what we're telling patients. You know, endoscopy should be performed, in my opinion, and gastroenterologists, I mean, okay, I'm going to say it, experts agree. A lot of experts that know the talk about agree, it should probably be moved up to every 5 years. There's lots of reasons why people with CVID should probably be getting their colonoscopies at 5 years as opposed to every 10 years without any other risk factors. That CVID is a risk factor in itself and moves you into the 5-year window. It would be pretty unlikely to have a bad event because of colonoscopy or an upper endoscopy. If they're worried about the scopes themselves and just the facility, being unclean, there's so much that goes in place for these surgical suites. You can shop around a little bit or go to a gastroenterologist that is recommended by primary care doctor or other patients. But I would say I would reassure you and say that would be pretty unlikely to run into bad infection because of unclean equipment, or even if we're talking about because of COVID. For Duke, patients before they undergo any procedure in the hospital have a COVID test before, and they're very good at screening for COVID before any procedures are done. So I personally feel that it is safe to undergo endoscopy in a trusted facility.
Thank you. Can you comment on probiotics?
Probiotics, I'm on the fence about those. I've had good and bad from probiotics. I will say that it's very unlikely for people to get into trouble with probiotics as far as getting a bacterial infection from the probiotics. It is very, very rare. There are case reports of that, but it is very, very rare. It really comes down to, will probiotics be helpful? I would say that we recommend probiotics when appropriate. Patients have been on, we think they have dysbiosis, which is where they just have either had antibiotics or they've undergone a lot of physical stress, and we need to retrain their gut immune system. Probiotics can be helpful. People use all kinds of probiotics. I really don't have a favorite one. As soon as I tell somebody what my favorite one is, they say that stinks and I want to use this one, and that one worked better. So I am non-committal with probiotics. I prefer that patients do probiotics in a natural form, like in yogurt, or pick up a refrigerated form of probiotics that you can find at a health food store or Whole Foods while they're on antibiotics, particularly if they're doing antibiotics for a long period of time. We usually will do antibiotics for 3 weeks, sometimes 6 weeks, to eradicate certain chronic infections. And then we'll say, we really want you on probiotics. And that seems to keep people out of trouble. So I think probiotics are appropriate during certain scenarios. I don't have a preference for which one people use, except for I prefer either the probiotics in natural food or probiotics that you can find refrigerated at like a health food store or Whole Foods.
Thanks. Switching to lungs. What are the strategies for coping with bronchiectasis?
Yeah, so bronchiectasis, we always focus on airway clearance. If you have bronchiectasis, depending on how significant it is, bronchiectasis could have just been discovered when the immune deficiency was discovered, or it could have been something that happened in time. The two most common causes for bronchiectasis in antibody deficiency patients, because other immune deficiencies, it may be structural, but in antibody deficiencies, it's usually thought to be due to recurrent infections that have occurred in the past. That inflammation weakened the walls of the airway, and you have bronchiectasis. Another common cause is reflux, particularly silent reflux. So to manage it, I always make sure they don't have an active infection that we're not treating, and I make sure they don't have reflux. Reflux is there, and it is nasty, and it causes terrible things. And people say, I don't have reflux. And we find out the reflux, and it's getting into their sinuses and in their lungs. So I make sure that those are not contributing. And then generally, I like for folks to be on some type of airway, we call it hygiene, respiratory hygiene. And usually that is airway clearance. And that can be with a device that helps cough and clear better. And it can be with steroid inhalers or other inhaler medicines that keep the airway open. We want to keep the airway moving. Incentive spirometers, airway clearance devices, because that junky stuff that sits on the bottom too long can get you into trouble. So airway clearance, well, defining cause 100%, making sure that we're not still doing so that's making the bronchiectasis worse. And airway clearance, and frequently we use inhaled medication.
What kind of treatment do you recommend for GLILD?
It's a fantastic question. It really is. So I am also in the camp of, I work with the group. There is, it's called chemotherapy, and I don't want to just say chemotherapy because it sounds really like a bad idea. If GLILD is diagnosed and we're certain that it is GLILD, occasionally we have patients that we watch and wait. We used to, when I was at the NIH for fellowship, we used to say, up the immunoglobulin. That's our first approach. We do as high as we can go for immunoglobulin, get those IgG levels high. That is still part of my programming. So I do try to keep folks' IgG around 1100 to 1300. I've seen benefit with that personally. It just doesn't treat GLILD. It just knocks down potentially further inflammation. Usually we find we need to do some form of immune suppression, not prednisone, never prednisone, no prednisone. I like the cocktail that's used. It's been recommended out of a group in Wisconsin that's been further validated, and that is to use rituximab, which is that chemotherapy drug, and azathioprine, something that is called anti-metabolite. It cuts down on that activity of those immune cells that are driving the inflammation and bringing about the disease. And that's usually done on a regimen that is sort of treatment up front and then like booster treatments throughout the year. And that can do wonders to control the GLILD.
Thank you. Some random questions. Is anemia related to COVID? And if so, how often?
Yes, part of COVID's unfortunate disaster that it can do to someone's body. I'm giving a talk about this actually next week. It really affects so many parts of our organ system, and suppressing our immune cells, anemia, and platelets can be seen with COVID. Was that the full question?
Yes. Is a low-grade temperature a symptom of CVID?
I don't know about a symptom, but many of our patients have temperature alterations, including some with a low-grade temperature and some that are very, very low. They have a very, very low temperature. They tell me the temperature is 96 as opposed to 98. Low-grade temperature is part of, particularly in CVID, when we think that the inflammation is high. So with CVID, depending on the genetics of CVID and what's driving it, we frequently see that the immune system is overactivated, certain parts of the immune system not able to complete its mission, so it stays activated, waiting to get the instructions and to complete its mission. And so there's a lot of time and energy and resources the immune system is using up to make an appropriate immune response, but never quite gets there. And there are this bystander effect, all the inflammation that we've talked about before in the lecture, and for some people, a rise in body temperature. It does contribute to fatigue because there's a lot of resources in some people with CVID that carry larger lymph nodes and may have a large spleen. They may have inflammation in the gut that's chronic, like we talked about in the small intestine. And that is energy your body doesn't need to be using up, but it doesn't know how to calm it down. So yes, that's a long answer, but we can see very commonly, and otherwise nothing is going on, minor temperature elevations, 99.1, 99.2 at rest in patients with CVID.
Thank you. What is CVID enteropathy? You mentioned it a couple times.
Yes, CVID enteropathy is a condition that really is quite specific to CVID. Now, symptoms of CVID enteropathy are generally, they're vague. They can be abdominal pain. It can be pain with eating. It can be altered bowel habits, diarrhea, loose stools, stools that look like the matter is not formed, where there's food particles in the stool. You may not lose weight, nothing else may be happening, but you may have all these other horrible things going on. People generally think of celiac disease because the same type of symptoms can happen with celiac. And when a biopsy is done to look to see if you have celiac disease, the pathologist in that biopsy will see changes in the lining of the small intestine that look just like you would in celiac disease. So CVID and neuropathy are the symptoms. It's the presence of CVID. And on biopsy, there are changes in the small intestine where the immune system is quite activated and you don't see the normal projections that occur in the lining that grab our food and allow us to absorb our food. Instead, it's flat. And frequently we'll see immune cells there that do not belong there. That combined picture, that pattern, is titled CVID enteropathy and is quite unique to CVID.
Thank you. Can you please define early for diagnosing osteopenia and osteoporosis?
So that depends a little bit. I've thought about starting it at 40. And that is generally a goal, is to just try to start at the age of 40. We get into trouble with insurance coverage unless we have a good reason. But our goal is to start between the ages of 40 and 45. Now, if there's other conditions that would make us start earlier, we would, but generally that's our goal to get started.
Thank you. I have a couple questions about sinusitis and people not reacting or not responding to their antibiotic treatment. They're on several rounds, that they don't get better, they get better, and then they're sick again instantly and back on antibiotics. What can they do to kind of get it cleared up? Are there tests that should be done to figure out why it won't go away or why it keeps coming back?
Absolutely. I spend the majority of my time answering these questions in the office because it's a plague. It's terrible. This happens all the time. And people don't know what to do. They're so frustrated. Very, very common. You're in good company. So the first thing that we do, if you were to come to me for the very first time, we didn't know anything, I would say to you, I need to know this is a sinus infection. I don't believe you. They're not sinus infections. And we would prove to ourselves that that's exactly what it is. So we need a culture, and I would probably get imaging. You'd be surprised how many times what we're treating is not actually in the sinuses, but forward. That's where the allergist in me comes out. So if that's the case, and it's not a sinus infection, we do our sinus hygiene, and people are great. They love it. It works. If it truly is infections, then we've been treating you wrong the whole time. You've got a bug in there that is not being targeted with the antibiotic, or you are simply not getting the antibiotics long enough. If you have a lot of inflammation in the sinuses and oxygen is not getting to the sinuses because everything is so plugged up, you have very different bacteria there. You don't have the usual bacteria. And your sinuses are not like the rest of your body. It's not like a toe infection. the blood flow to the sinuses is very small. So you need, if you have chronic sinusitis, that antibiotic gets there by diffusion. So it's well known you're going to need 10 days or more of antibiotics for that antibiotic concentration to build up in the sinuses where the infection is. Because just when you're starting to get a response, you're done with your antibiotic and you haven't reached that critical level where you're killing the bacteria and actually taking charge of the infection and clearing it. You just haven't been given a chance. So if it's truly an infection and we've cultured it and we've got the right antibiotic, you're looking at 3 to 6 weeks of antibiotics, and we will clear your infection for once and for all. So that would be my recommendation.
Thank you. So I have two questions that are kind of similar. How do you explain to specialists that you're a zebra and the tests that you may need to have done are going to be different, using maybe rheumatology and RA as an example, that they need to kind of look at testing a little bit differently? And how do you get them to understand why, what your immune disorder is and why you need those different sorts of tests? And how do you find those doctors that understand all of that?
Yes, very good question. So it is a challenge. It's even a challenge for me to have our subspecialists understand what I'm asking. You know, they may send a very rude note back to me saying, you need to go back to medical school. This person does not have this. And, you know, that's okay. They're obviously not a good fit, but I try to bring some information. So if you have an immunologist in your corner, then I would have them look up some articles or some recommendations. And the Immune Deficiency Foundation may have some resources on their chapters about what they're looking for. No doctor really wants to make the wrong decision. They really, really don't. But they also think they're right a lot. So innocently, they could be stubbornly thinking they're telling you what's going on when they need to stop talking and be a little receptive. So the intent, so oftentimes you can take a physician who means well, but just needs more education and has to be willing to listen. And then you can develop that relationship. You don't have to get rid of them, but you need someone in your corner, or you need to look for resources, and the IDF, I'm sure, can help with that this is why this is recommended, and have them do some reading on their own. And then before you know it, it'll be their idea, and you'll get the help that you really need. So sometimes it's just that little push that, you know, or you can just, you know, or you can have a heart to heart and say, look, it may not be what you normally do, but this is really important to me. This is the information that I've been given. This is what I know I need to get done. And if you're not the right person for it, if you'll, you know, then tell me if this is gonna work. And sometimes they'll back down because they'll, you know, you'll reach the real doctor in them, which is just there to really, really help. So my two approaches would be, you know, show them some information, and it may turn out to be a great relationship, or you know, appeal to their altruistic side that all doctors really, really are. You know, come across that way all the time, but truly they're there to help. Give that a try.
Moving on to allergy issues. So this person wants to know, they are triggered big time by allergens. They wear an N95 for years, but they can still smell things intensely. They have CVID, then they have an asthma attack. There's another person who talked about allergies, and is that part of having a primary immune disorder, having those severe allergies?
So it certainly can be. It's another one of those sort of hard things to understand. If your immune system is not working strongly, you're not making antibodies, how can you start making these allergy antibodies? Because you can. And it's just like we think about autoimmune disease, you know, we're recognizing things that should be benign, our own body, tree pollen. But the immune system is like, this is much easier for me than streptococcal pneumonia. So I'm gonna make an antibody response against this. So you certainly can have an immune deficiency and have bad allergies. And there is a lot in our field where that is very, very well known. And I think the first thing to do would be to determine what those allergies really, really are. And if they are our environmental allergies that we can make a great deal of impact with, then there are treatments. We should not ignore that, because allergies affect respiratory tree and sinus infections. And so we manage that. You know, it may be that allergy shots are going to work for you. It may be a biologic. Just because you have immune deficiency, there's a lot more to you, and you can still react and respond in ways that somebody without an immune deficiency wouldn't. And there's no contraindication, no reasons why you couldn't be treated just like a patient with bad allergies.
All right, so last question, the elephant in the room, lots of questions. The CDC has updated their guidelines, and people want to know, masks are not going to be required now for people who have been completely vaccinated. But how does this affect those in the PI community who have been vaccinated and those who have not?
So, Colleen, you remember in February, I am on the mask side of things. So for people in the PI community, and for me, I am going to continue to wear a mask. There's lots of reasons why I'm going to continue to wear a mask. It is unfortunate that our communities will stop wearing a mask very likely. I think as soon as that recommendation comes about, we can have a very long scientific discussion on is that appropriate or not. But I think for our little group right here, it makes complete sense that a mask protects everybody who's wearing it. And I still think that if you are vaccinated, if your family is vaccinated, a lot of the rules are still going to apply. So yes, wear a mask, 6 feet of distance. I certainly would feel more comfortable about going to the grocery store if you've been vaccinated. It depends on your immune deficiency, of course. But I think there's some things that we can be a little more flexible with. You have no idea how many people around you are vaccinated and who are not. How do you know that the people who are vaccinated are the only ones not wearing a mask, first of all? And we don't really know what we do in May. In October, we're going to be doing that and then some, right? We're going to be no restrictions whatsoever by October. And how we don't know what the variants are going to be doing and how effective the vaccine is in October. It might be wildly effective right now in May as an individual, but we don't really know the durability of that response long-term because we haven't been in the future yet. So we don't know. And we also don't know exactly the durability of our antibody responses. Hopefully we've all generated them, or cellular immunity. What's going to happen is more variants are emerging. And so there's a lot of reasons to still be cautious. And so, yes, wearing a mask, you know, it'll be all the usual guidelines, I think, should still stay in place for people with primary immune deficiency. Much longer conversations on what you can and cannot do. I will say, though, that the antibody responses are going to be more, it's quite difficult to interpret antibody responses. So I think it's going to be helpful to think about the other parts of the immune system that are developing immunity. And I think that's where a lot of our PI community that have antibody deficiencies are going to develop that protection. It's going to be through the other parts of the immune system, but we don't have a way to really measure that. So keep up the good fight, keep doing everything that you feel safe with, and definitely wear your mask.
Thank you very much. And I will say, it seems like a long time ago since we had that meeting in February. And also just for everybody here, as Kathy mentioned earlier, we are going to have a session on COVID and moving forward and things to do and what we know in June at the PI conference. So that is where you can get more information also. And now I will thank Dr. Lugar again and pass it back to Kathy.
Amazing. And yes, Dr. Lugar, thank you so very much for volunteering your time to be with us tonight and share such wonderful information. And thank you to everyone who has hung in there with us until the bitter end this evening. And thank you to our sponsors. Wonderful to have you here and have your support. And we look forward to seeing many of you next week at General Care for Individuals with Primary Immunodeficiency. And then, of course, the other two forums here will be up on the calendar events within the next couple days. And at this time, thank you again for joining us tonight. And we hope you found the information helpful. Please remember, IDF is with you every step of the way. Take care and be well. See you next time.